All right, thank you. I'm not used to speaking into a microphone, so if I'm too loud or too quiet, thumbs down, I guess. Thumbs up are good. All right, so as introduced, my name is Dan Pederson, and I am going to be talking about advances in medical implantable device technology for the treatment of epilepsy. I've been working on treating epilepsy for about 8 years now. So I'm no expert, but I've seen a lot of things. So here we go. First of all, we need to talk about what is epilepsy. It is a neurological disorder. It's characterized by a sudden, recurrent episode of sensory disturbance, loss of consciousness, and or convulsions. This is just another way of saying seizures. People who have epilepsy have seizures. In fact, if you have more than one seizure in a separated time, separated by 24 hours, you can be diagnosed with epilepsy. It is associated with abnormal electrical activity in the brain. In fact, this is actually a picture of an EEG. An EEG is electrical measurements taken usually on the scalp, sometimes on the surface of the skull, and sometimes even on the surface of the brain that measure the electrical activity of the brain. The image on the bottom shows a pre-ictal period, which would be a normal period, and then about halfway through, it's pretty obvious there's something going on. It's a synchronized firing of electrical energy in the brain that kind of self-propagates, and this causes a seizure. Now, a seizure can be a couple of different things. The typical seizure that you may have seen on TV or even somebody in person is somebody falling on the ground and shaking, convulsing. It can be very violent. It can be very scary. There's other kinds of seizures called absence seizures. These seizures, people could be talking to you mid-sentence and then just stop and stare for maybe 5 minutes. Or maybe they'll fall over but not seize, or I guess they're seizing, they're not convulsing. This is called an absence seizure. These are also very dangerous, as I will go into. So who's affected? It's about 1% of the US population. That's a lot of people. Most of us know at least 100 people. I think most people know about 300 people by name. So most people, I'm assuming in this room, at least know somebody who has epilepsy or somebody who's been affected by epilepsy. Many times families are greatly affected by somebody who has epilepsy. It's also kind of a private disease. In fact, all diseases are pretty private. You don't normally go around telling everybody that you have seizures all the time. So you may actually know somebody who has epilepsy and you don't know it. 25% of these cases are intractable. This means that these people have no medications they can take that work. They have no scheduling that works. They just have to live with their seizures. There's nothing we can do for them. These people are the people that medical devices are made for. And we'll go into that in a minute. As I said earlier, anybody who has at least 2 unexplained seizures can be diagnosed with epilepsy. And before I go into treatment, I want you to just kind of think about what would it be like to live with epilepsy. A lot of people think seizures and falling and shaking, and that's really bad. That sounds really painful, kind of embarrassing. And it can be. But one of the hardest parts is a person with epilepsy, in general, spends less than 1 hour a year seizing. All the other hours, they're wondering if they're going to seize. And that's where it's really difficult. You can imagine going down the stairs with a load of laundry, or getting in a car and trying to drive, or cooking over a hot stove, or taking a bath by yourself. If you lost consciousness for just 30 seconds, any of those activities would be very, very dangerous. Most people with epilepsy who are seriously injured or die, it's because of usually trauma to the head because they fell. It's not usually because they die of status epilepticus, which is a seizure that doesn't stop, or SUDEP, which I'll talk about later. So it's a very difficult disease. It's something that oftentimes hits children, and they live with it for their entire lives. It also affects caregivers greatly. Parents, spouses, even children. It can be very, very difficult to deal with. So let's go into treatment. How's epilepsy managed? First of all, this list is kind of in non-invasiveness to most invasive for treatment. Scheduling is one way. They think that stress maybe brings on seizures. So people with epilepsy oftentimes go to bed at the exact same time every night, wake up at the same time, whether it's a weekend or whether it's for work. They eat at the same time. These things help. Service animals, it's not very common, but there are some dogs who can sense when a seizure is going to start. And that can be great, but it's not very common, and it's not really something that people rely on. A ketogenic diet is another thing that people have tried that sometimes helps. You'll notice there's a little bit of a theme here. We think it works and we're not sure why. That's kind of how treating epilepsy is. There are pharmaceuticals. These are mostly in terms of barbiturates of Valium. What's difficult about pharmaceuticals, I don't want to offend any pharmacists in the audience, I have one already. What is difficult about pharmaceuticals, well, first of all, there are competitors, but other than that, we don't compete. This is treating illness. If it works, that's great, and I love it. But what's difficult about pharmaceuticals is because you don't know when you're going to have a seizure, you have to be on them all the time. So can you imagine waking up and taking Valium every single day? It's pretty hard. Let's say you're a teenager trying to get through high school, and you're on drugs all the time. It can be really difficult to learn, to develop. A lot of people would rather just have seizures than be on these drugs. So they turn to resection surgery. This is where they actually go in and take out a part of your brain that they have determined is where the seizures start. I mentioned earlier when I had that picture of the EEG and you saw it going up and down, oscillating. That usually happens in, well, I shouldn't say usually, oftentimes it happens in one point of the brain that kind of goes haywire and then it spreads throughout the whole rest of the brain. If they can get to that point and take it out, that's great. You won't have epilepsy. This actually can cure epilepsy. Now there is a problem. Our brains are kind of important, and sometimes that foci where the seizure starts is in a spot that we can't take out. You kind of need certain parts of your brain to survive. Sometimes it's in a part that we could take out, but it's so deep in your brain that we can't get to it. And so then you're not a candidate for resection surgery. At that point, you look at medical devices at this point in time. So there are two different types of medical devices currently approved by the FDA to be used to treat epilepsy. One is a vagus nerve stimulator, and I'll be talking about that extensively in this talk. And another is a deep brain stimulator. Deep brain stimulation is done by a company called NeuroPace. It was just approved in 2013 for use in the United States, and it's had some mild success. It has about the same efficacy rates as vagus nerve stimulation. Some people think it's there's benefits for both of them, and I can talk about those later too. But we're going to focus on vagus nerve stimulation now. So vagus nerve stimulation, the vagus nerve is the 10th cranial nerve. It goes, we can access it in your neck. It actually goes throughout your entire body. I'll show that in a minute. This middle picture shows what a vagus nerve stimulator actually looks like. They implanted in a surgery that has 2 incisions. It's about a 3-hour surgery, and the first one is the most difficult. It's in your neck, and they have to find the vagus nerve. It's actually in a sheath connected to your carotid artery. So you have to be really careful when you're trying to isolate it. That said, I'm not trying to scare anybody. This has a very high success rate. The carotid artery is big. You can't really beat it up too easily because it's really important. And it also makes it really easy to find the vagus nerve. In fact, I do surgeries on rats where the vagus nerve is much, much smaller. And the easiest way to find it is you just look for the pulsing carotid artery, and you can find it that way. I haven't killed any yet, so that's good. So what they do is they go in and they wrap this little helical electrode, which I think this has a pointer on it. Anyway, the helical electrode, which is kind of the helical thing there in the middle, that wraps around the nerve. And then they tunnel it down to the chest in the subclavicular pocket, and that's where they put, it's almost like a pacemaker. And what this device does is it stimulates with electrical, with electricity, with current, into that nerve at a preset setting. So there's a certain strength of the stimulus, a certain frequency of the stimulus, and it will stimulate for about 30 seconds every 5 minutes. And this stops seizures. And don't ask me why. We've been studying it for 20, well I haven't, but for 20 years to figure out why this works. But it does. Now I say it works. It sometimes works. Let's get into that. This is just another picture showing what the vagus nerve actually innervates in the peripheral nervous system. Lungs, stomach, kidneys, liver, heart, colon, all these things the vagus nerve goes to. It's very important to stimulate it correctly because it can cause some adverse side effects. 1/3 of patients get a greater than 50% reduction in seizures, which includes patients who actually have no seizures for the rest of their lives after they get this device. 1/3 of patients get a less than 50% reduction, and 1/3 have nothing. The problem is we have no way of knowing who is going to get efficacy from this treatment and who won't. So many people go in to this surgery, they spend, well, I guess their insurance company spends a lot of money on it, and they recover for 6 months, they turn the device on, and it doesn't work. This is a problem. We don't want to have to do this to people who have already gone through many, many treatments, many years of trying to manage their epilepsy, to find out that honestly the last ditch effort they have to treat it doesn't work. So this is what we're studying here at Purdue. I guess not here, over there at Purdue. So let's go into epilepsy research at Purdue. I'm going to just list off these bullet points. I can't cover all of these things, but I can answer questions about them afterwards. I can hang out at the end if you have questions. I actually work in the Center for Implantable Devices, which is a collaboration of professors at Purdue who all are in the biomedical engineering department or the electrical engineering department, and some in the biology and some in the neurology department. And we make implantable devices. That's what we do, and then we use them to research these different things. And epilepsy is a pretty big thing that we research. So the first two, A and C, autonomous nerve control, I'm going to talk about here in a minute. And then SUDEP is actually my project that I'm going to be working on and hoping to get a PhD in a couple of years with my research in collaboration with John Jeffries over at Oxford University. Seizure detection algorithms, DBS, and closed-loop VNS. If you're interested, I can talk about those later, but it is just some of the things we do to study epilepsy. Now, all of these things are made possible with a fully implantable wireless device that we made at the Center for Implantable Devices. We've made 3 generations. We're just finishing the 3rd right now, and I'll be finishing my presentation talking about that. I'm an engineer, so I love that part. So let's talk about some autonomous nerve control. Some of these words are going to get pretty technical, and I hope you don't get confused. I'll try to explain things here. So the vagus nerve, let's just talk about the vagus nerve a little bit. It's not a wire that just connects to your brain and then connects to different parts of your body that just sends electricity whenever it gets it. Don't think of it as a copper wire. It's a bundle of thousands of nerves. So this image on the bottom, I guess you're right, bottom left. The image on the bottom left is not the vagus nerve, but it is a representation of a nerve bundle. And if you see all those little blue bundles inside, those are called nerve fibers, and those go all over the body. So if I stimulate that nerve, some of those fibers are going to get electricity more than others. And some of those fibers go to your stomach, and some go to your heart, and some go up to your brain. We don't actually know where all of them go, but we're still working on mapping those. In fact, a professor at Purdue is one of the leading professors at mapping the vagus nerve and where it goes. So you may ask, well, why do we care if it goes to the stomach or if it goes to the liver or wherever it happens to go? Don't we just care about where it goes up into the brain? Well, we don't know how vagus nerve stimulation works, and it's thought it might even work because it changes how your hormones are released. And so honestly, we just don't know how it works. So what we need to do is figure out what these nerve fibers are doing when we stimulate them, and see if that electricity is going to different parts of the body, and which patients who get good efficacy and good treatment from a certain stimulation, which of their fibers are firing, and can we just fire those in everybody else? This brings up a kind of an issue with electrical stimulation in patients. If I apply an electrical stimulation to my vagus nerve, and let's say it's an amplitude of 200 microamps and a pulse frequency of, 20 hertz. So if I apply that electrical stimulation to my vagus nerve, the fibers in my nerve will fire differently than the fibers of any of your nerves. And it's because it has to do with how that electrode is encased around your nerve. It also has to do with who your parents were. So, and even more than that. If I have this implanted and I apply that stimulation to my nerve, if I do it again next month, different fibers are going to fire. Because our bodies are really good at getting used to things and adapting to things. That's why you don't actually feel your shirt on your body right now, because you've been wearing it and your body has decided to stop listening to those electrical signals coming from your nerves that are sensing that your shirt is on your body. Except for now, you probably can all feel it because you want to see. So that's the same problem with vagus nerve stimulation. If we keep zapping this thing, it'll just say, well, I don't want to listen to that anymore. So we actually have to change how we stimulate the nerve over time in order to still fire those same nerve fibers. Now, which fibers, we don't know yet, because we don't even have the way to pick the fibers that we want to stimulate, so we can't even study that yet. Well, actually, now we can. That's what autonomous nerve control is all about. We stimulate the vagus nerve, and then we have a recording electrode that can listen to see what is actually happening, which of these nerves are firing. And depending on the timing of the electrical activity that we see as a result of our stimulation, we can determine which nerves are firing. And then we have a computer algorithm that has kind of an artificial intelligence to it that can determine which stimulus waveforms will stimulate those fibers in your particular vagus nerve. And so using this autonomous nerve control, we can actually take out of the equation different patients and take out of the equation time, which could allow a physician to find a stimulus for fibers that works for any patient. And then we can use that to better help those 2/3 of people who don't get help from vagus nerve stimulation. So that's enough about autonomous nerve control, except for kind of remember everything I just said. We're going to go into suit up just a little bit. How am I doing on time?
60.
About 10 more minutes? Okay, good. We'll have some time for questions then. So, suit up. Sudden, unexplained, or unexpected death in epilepsy. This is a very, very hard problem to study. It's experienced by people with epilepsy who are otherwise healthy. So, this is very hard to study because we don't usually hook up healthy individuals to heart monitors and respirators to determine what happened when they died. It's actually very similar to SIDS, sudden infant death syndrome, where otherwise healthy infants go to bed and never wake up. This is very similar. People with epilepsy have the same problem. It's a low percentage. It's about 15,000 deaths a year in the United States, but it's significant. It's not actually related to a seizure, so when they find these patients, they can determine that they haven't just seized and suffered status epilepticus, which I mentioned earlier. If you seize for more than 30 minutes, you can actually die. It's a lack of oxygen to the brain. So the unexpected nature makes it very difficult to study. Now there's a Professor John Jeffries over at Oxford University, and one of his graduate students, Alexander, who I've met and worked with for about a year now. They did some work to determine that during seizures, sometimes people's heart rates get really high. And sometimes after the seizure, it doesn't go back down. And so the thought is perhaps this can happen spontaneously and actually have a heart rate spike without a seizure, and that could cause death. And this could be explained, an explanation of SUDEP. Well, how do you study this? It's really hard to study. Well, let's go into the research. So our thought is we have this implantable device that we've made at Purdue, which I'll talk about here after this topic. We can monitor biological signals in rats, or in people, but we're not licensed to do that, to determine, we can monitor the biological signals 24/7 for the lifetime of the rat. There's no battery, it's all wirelessly charged. We implant it once, and we can get heart rate, we can get ECG, we can get EMG, EEG, all these different Gs. And so if we have all of that information, and we can actually determine if these rats are experiencing tachycardia, which is the increase in heart rate after a seizure, then maybe we can control that. There's he's now a doctor, but he was a graduate student in our lab that I got to know quite well. His name is, I guess he's Dr. Kurt Ching now. His research was on if you stimulate the B fibers, there's A, B, and C fibers, there's more, but if you stimulate the B fibers in the vagus nerve, they're kind of mid-range size fibers. If you stimulate those in the right vagus nerve, we can actually lower the heart rate. So the vagus nerve doesn't control the heart rate. If you actually cut someone's vagus nerve, they won't have a very pleasant existence, but their heart will still beat. But you can modify the heart rate. So if we can stimulate the B fibers in the right vagus nerve, then we can determine when a seizure is starting, we can see that heart rate spike, and we can stimulate and slow that heart rate down. And if we can do this in a series of studies and show that this reduces stress on the heart and reduces this possibility that a runaway heart rate could be causing SUDEP, this would be a great step forward in SUDEP treatment. And it would be a great step forward because so many people already have VMS devices. So this would be using a device you already have in order to reduce your heart rate during a seizure and stop you from having these very stressful attacks. Now what's important is, let's bring back all that stuff I talked about, ANC, autonomous nerve control. In order to stimulate the B fibers, we have to have that technology, because otherwise we can't just pick which fibers we want to stimulate. We don't have the ability to do that. So we'll be wrapping that in as well. And then finally, my final topic is going to be talking about this BioNode. We call it a BioNode because it's a cool name, I guess. And that is it wrapped around a penny. This is a Generation 2 device. It has, the final device will measure 7 by 10 millimeters. This can actually be implanted in a mouse. Mice are that big. It has 2 recording channels, so we can record any biopotential we want. We can record EMG, which is muscle activity. I can record ECG, which is heart activity, EEG, which is brain activity, and respiration. It can also be fitted with a pressure sensor to do things that we've been studying in urinary incontinence to study how the bladder works. It has 1-channel stimulation, so we can do vagus nerve stimulation. We can do DBS, deep brain stimulation. So this particular implant is being used, I believe, in 10 or 11 different research projects and about 5 or 6 other external collaborations to study anything varying from Parkinson's disease to epilepsy to something called transmuscular reinnervation, which is a technology to reinnervate the missing limb of an amputee by measuring the EMG activity of a nerve that's been traced to a different muscle. And I can talk about that, but that would take me hours to talk about. So this device is being used all over the place, and it's been very useful for us, and we're just finishing up the 3rd generation. It is fully wirelessly powered, so we actually put it in a rat or a mouse, and then they go in a special cage that has it's called a resonant cavity that has a rotating electromagnetic field. I can go into that too if you guys really want to. And that will actually power this implant so that it can take its data and then it can beam the data out to a base station that can gather that data and run algorithms on it, and then we can reactively stimulate in order to try to treat some of these neurological disorders. And let me just finish up with some acknowledgments. Of course, my wife and my 2 kids. I thought I'd put them above my professor to keep things from being awkward. My professor, my advisor is Professor Pederson out of Purdue University. I want to acknowledge Professor John Jeffries from Oxford. And then all the remaining people are people who have worked in our lab or at the Center for Implantable Devices. And finally, I want to acknowledge the Graduate Research Fellowship Program that's been funding my research for the past year and has promised to continue funding it. And Cyberonics, who has also funded our lab. And a full disclosure, I've actually been a consultant for them for about 3 years, and they continue to be very supportive of our lab. So I guess at this point, I'll just open it up for questions. Yes?
So is this something that you could think about using in situations where seizures happen post-trauma, where it's not epilepsy, but it's a post-traumatic issue, and managing usually often on an inpatient basis when something's happened and there's post-surgical seizures. If you don't have epilepsy, but obviously trauma to the brain has created this. Is there in the future, do you think that could be something that could avoid that?
It's a good question. Now, first of all, if you have a head trauma and it causes a seizure or 2, you're right, that's not actually called epilepsy. However, if you continue to have seizures for the remainder of your life, or even just a couple of months, I'm not an expert on that, if you continue to have seizures that are unexplained in nature, then yes, you would have epilepsy. Now, I don't believe that they would use it in that situation because they do have pharmaceuticals, and if you're in a hospital situation, they probably would just give you barbiturates to take care of that. And they do have fast-acting pharmaceuticals. If you start having a seizure, then you can come in and stop. The real danger of epilepsy is when you start having seizures at home, when there's no one around, or even if there are people around and you're doing something dangerous. A medical implantable device is more for long-term care. Yes, sir?
When the device sends the signal, is the patient aware that it's happening, or is it subliminal?
And that's another good question. In fact, it will expose how much we don't know about VNS. Currently, when Cyberonics does an implant and the person recovers and they go to turn on the implant, they will crank up the power until it hurts, and then they'll turn it down. In fact, somebody with a VNS device, one of my wife's uncles has a VNS device, you'll be talking to him, and about every 30 seconds, every 5 minutes, his voice will get gravelly. And that's because the vagus nerve innervates the larynx. And so his voice just gets gravelly, and that's worth it for him to treat his epilepsy. On the right.
First, a comment. Your speech is an example of how an engineer in a technical area can be entertaining, and that was delightful.
Well, thank you very much.
And the question, after two good questions, you deserve a bad one.
Okay.
Does anybody have any theories about what causes epilepsy, why some people have it and others don't?
That's actually a good question. The reason why is because it brings up again why epilepsy is so hard to study. An epileptic seizure, well, somebody to be diagnosed with epilepsy is that they have to have 2 unprovoked seizures. So if you have a brain tumor and that causes you to have seizures, you don't have epilepsy, you have a brain tumor. So the definition of the disease is that we don't know. So that's kind of my answer, I guess. We don't really know why people have epilepsy. We can tell that their brain chemistry is changed, and a lot of people think that's probably due to the epilepsy, not as a cause of the epilepsy.
When you have an implant, are some of the patients still on medication even after the implant?
Yes.
If it's not.
Actually, oftentimes what happens is people are on medication, they want to be off of the medication, they get the implant, they keep on their medication and then titrate it down.
Oh.
And then oftentimes what happens, sadly, is they get benefits from the treatment for a few years, and then their seizures start coming back, and so they start adding more, and then they'll end up with the same cocktail they had before they had the implant, which is, again, maybe related to the fact that over time the efficacy reduces. In the back.
So, how widespread are these? How much usage are these devices getting? And if somebody had one implanted and it didn't work, have you tried a second time to see if the second implant might work?
Okay, so as for the first question, I believe that Cybronics reports that they implant in the order of thousands to tens of thousands of these a year, maybe even 100,000 on I don't want to say a good year, it's not really a good year, but for them, business-wise, they implant in the order of tens of thousands a year. The NeuroPace is pretty new, so they don't implant as many, and I don't know what their numbers are. As for trying again, people have the ability of turning the device off if they don't like it. Oftentimes when they call it explanting, they'll go ahead and take the device out, but they'll usually leave the leads in because it's a high-risk surgery to go in and take them out. I haven't heard of anybody having it taken out and then having it put back in, although some people get a right vagus nerve. They usually do the left because it doesn't innervate the heart as much. Some people might do the other one. Basically, if you already have a pacemaker and it's taking up that side of your chest, they do the other one. But no, I haven't heard of it.
Okay. You have time to stick around for others' last questions?
Yes, I do.
Okay, thank you. Thank you for your presentation.